Well, greetings everyone, and welcome to ECGweekly.com. My name is Amal, Mattu. I'm a faculty member at the University of Maryland School of Medicine in Emergency Medicine. And for many of you who have been following our weekly EKG videos, cases of the week on the University of Maryland website, many of you will know that we are transitioning now to a brand new website, new, upgraded ECGweekly.com. This new website is going to be collaboration of three of us, actually, myself and also Dr. Rob Blankenship, who is an ultrasound guru. He is an emergency physician, and he has done some incredible online work that we'll talk about in the coming weeks. And also Dr. Ali Farzad. Ali is a graduate of our emergency medicine residency at Maryland, after which he did an emergency cardiology fellowship, and then he headed south. He now works in Texas at one of the Baylor affiliate hospitals, and he has continued to have a very intense interest in emergency cardiology. And again, for those of you that have been following our weekly videos of the week, Ali is the person who writes up the summaries and does a lot of the written commentaries as well. So the three of us are going to be working hard to bring you a new upgraded version of those EKG videos of the week. So what are we going to be doing new with this program? Well, we're going to be adding more EKG content. If you've been a listener over the past 3 years to the videos of the week, you know that perhaps you've sensed that I've always been in a big rush to get these things done. I've really tried to limit the videos to about 10, maybe 15 minutes at a time. Well, I'm not going to rush anymore. I'm just going to take my time and try to provide as many pearls as possible. And so some of these videos might go 20 minutes or maybe even longer. But I figure, you know what, if you get tired of it, you just hit the pause button and come back later. We're not going to shortchange any of the learning that's out there. And I hope that with all of this learning and the redundancy and repetition, there's going to be tremendous learning and improvements in knowledge in electrocardiography if you watch these every week over the course of the next year, 2 years, 3 years, however long we go. We're also going to be adding more general emergency cardiology pearls. So we're not going to just limit the pearls to electrocardiography. We're going to expand a little bit. We're going to do some more cardiology management pearls as well. In addition, because we are upgrading, we are going to be charging a subscription fee, but we're going to keep it really, really cheap. We're not looking to make money off this thing. And so we're going to try to price this out at what amounts to less than the price of a cup of coffee a week. So the way I see it is if you're willing to spend the price of a cup of coffee a week, you're going to save lives by improving your knowledge on electrocardiography. So this is going to be really, really cheap. And by some way, if I end up making a little bit of a profit, what I'm hoping to do is actually fund an EKG or ECG research contest for people out there and try to encourage more people, especially students, residents, and junior faculty, get involved in electrocardiography research. Because I think if we get more people involved in electrocardiography research, it's really, again, going to save a lot of lives. So as we go through this, I really want to welcome your feedback. If you have any comments, questions, please email them to me. I always put my email on these cases, and I welcome any emails that you have. If you have questions or comments, just email me directly at my personal email, amalmattu@comcast.net. Don't go looking through the internet for my email. This is it. That is my email. You don't have to search anywhere. Don't send it to my university account. Send it to my personal email if you have any questions or comments or interesting cases. If you do have any interesting cases that you want to share, please, by all means, do so. And we'll try to get the interesting cases that have the best quality images on this website. Also, for those of you that are Twitter fans, this is my Twitter name, at Amal Mattu, and I will be sending out announcements. Every time we post a new case, I'll send an announcement out on Twitter. So if you want to keep up with that, just go ahead and follow me on at Amal Mattu. And with that, we're going to go ahead and get started with our first ECG case of the week for the week of January 5th, 2015. This week's case is a quick one and probably one that many of you have heard a similar case of before if you've been following the EKG videos over the past few years. This was sent in by Dr. Daniel Kwan, who is a third-year emergency medicine resident at University of California, San Francisco's program in Fresno, California. Daniel was taking care of a 61-year-old man who came in with chest pain. And this patient does have a few significant cardiac risk factors. He's got hypertension, he's got hyperlipidemia, he's a former smoker, quit a number of years ago, but does have a significant smoking history in the past. So right up front, we're obviously concerned about this patient, and there's some more concerns that we're going to talk a bit more about here. He's got substernal chest pressure with radiation down both arms, and I'm going to highlight that word radiating. His chest pain is worse with walking, with exertion, and he also has shortness of breath with exertion. It gets better with rest, and there's a really bad word right there. He gets nausea and diaphoresis. So right up front, he's got three of the worst things that you can have, the most predictive factors that will increase the likelihood that your patient with chest pain is going to end up ruling in for ACS. Now, many people out there have learned, and I've learned, all kinds of different things that we're supposed to worry about with regards to chest pain that should make us worry about ACS. We've learned about lightheadedness, nausea, vomiting, substernal location, pressure, if people use the word pressure or squeezing or tightness. We've learned about diaphoresis, associated shortness of breath. We've learned to worry when patients' pain is worse at rest. We also worry when their pain is worse with exertion. What are the factors that actually increase the likelihood that somebody is going to end up ruling in? It turns out when people have looked at the world's literature, there probably are only 4 factors associated with chest pain that significantly increase the likelihood that your patient is going to rule in for ACS. If the chest pain is associated with radiation, especially bilateral, if the chest pain is associated with diaphoresis, and if the chest pain worsens with any exertion. And the one other point is that if the patient's chest pain is associated with the vomiting. Those are the 4 factors that markedly increase the likelihood that the patient's going to rule in for ACS. And here, we've got a patient with 3 out of those 4 factors. Everything else we've learned turns out to be fairly nonspecific. But we're really worried about this guy because he's got 3 out of the 4 factors, which the literature shows is highly specific for ruling in for ACS. Okay, let's keep moving forward. The guy's got a little bit of bradycardia. His heart rate's only 50. Blood pressure is borderline systolic in the 90s. His respiratory status seems to be okay. His lungs are clear. The rest of his exam is fairly unremarkable. So let's get on to the electrocardiogram. And here we go. Here's the initial ECG that was obtained on this patient, and you'll notice right up front that there are some concerns here, especially in those limb leads. So let's blow those up, all right? There's the limb leads. So first of all, taking a look at the rhythm to start with. Probably what you're going to notice is that in some of his limb leads, he's got P-wave inversions, right? Inversions in lead 2. Lead 3 is kind of a mess. There's a lot of artifact there. I'm not really sure what to make of that, but it's definitely inverted in AVF also. And the other thing that you might notice, actually, let's go back for a second. If you look at some of the precordial leads, there's also some inversions out there. V4, maybe in V5, maybe even in V3. So these are not normal looking P waves at all. So they are inverted P waves. And you might also notice that the PR interval is really short. So there's a short PR interval, and the P waves are not upright in the limb leads. That means that this is not a sinus rhythm. Sinus rhythm is defined by having, P, QRS, P, QRS, P, QRS. But there should be a normal PR interval. In other words, PR interval should be at least 120 milliseconds. And the P waves should be upright in leads 1, 2, 3, AVF and AVL, and inverted P waves in lead AVR. That's how sinus rhythm technically is defined. If the impulse is coming from the sinus node, the P waves should be upright in all of the limb leads except inverted in lead AVR. So this is not a normal sinus rhythm with the short PR. This is probably a junctional rhythm, and that would certainly go along with why this patient has a heart rate in the 50s. So this is a junctional rhythm going on. So junctional rhythm rate is about 50. There's ST elevation also in lead 3, not in any of the other leads though. And in fact, there's actually a little bit of ST depression in lead AVL and lead 1. This patient does not meet cath lab criteria, does he? He's only got ST elevation in one lead, but he's got some ST depression in a couple of the other leads, lead 1 and AVL, and that ought to make you a bit concerned as well. Okay, so let's digress for just a moment here, and let's take a look at a no-brainer acute inferior wall STEMI, all right? Now, nobody would miss this. This person is clearly having an inferior wall STEMI, and maybe there's some lateral involvement as well. But I want to focus your attention on lead AVL. Take a look at AVL. The patient has a T-wave inversion with ST depression in lead AVL. And nobody pays any attention to that because there's already, as I said, this no-brainer STEMI going on in 2-3 and AVF. Well, why is there ST depression in lead AVL? That's a reciprocal change. Nobody gives any thought to the reciprocal change, but the reason why I want you to pay attention to lead AVL and the reciprocal change in lead AVL is because sometimes the reciprocal changes can occur first and then the STs start to rise a little bit later on. I once remember hearing an interventional cardiologist tell me that if you took a patient to the cath lab and you tied off the patient's right coronary artery, for example, the first thing you see is not ST elevation in 2-3 and AVF. If you tie off a right coronary artery, he said, the first thing you actually see is ST depression and a flip T wave in AVL. And then 5, 10, 15 minutes later, then you see the ST elevation in 2-3 and AVF. In other words, the reciprocal change occurs first. Now, I didn't ask him how he happens to know that if you just happen to tie off someone's coronary artery for kicks, that's what you end up seeing. But that's what he said. And also, this is something that Marriott and other electrocardiography experts have talked about for decades. Key point here, reciprocal changes sometimes can occur before the ST segment elevation. And if you recognize the fact that a flip T wave and ST depression in AVL is a reciprocal change, then you ought to be thinking about following up with serial EKGs because maybe that patient has an impending inferior wall STEMI. Well, that's exactly what Daniel was worried about. So this was, again, the initial 12-lead EKG. He saw the flip T wave in AVL and the ST depression. He also noticed that in lead 1, and he was concerned. So he decided to go ahead and repeat the 12-lead 20 minutes later, only 20 minutes later. And sure enough, 20 minutes later, this guy, still with ongoing chest pain, now starts to develop significant ST elevation, maybe a bit in 2, but definitely ST elevation with big Q waves now in lead 3, and ST elevation with Q wave in lead AVF. And this is your definite inferior wall STEMI. In fact, there's just a tad bit of ST depression in lead V2 and in lead V3 with tall R wave. So maybe this is posterior involvement as well. We'll talk about posterior STEMI in an upcoming segment. So what happens next? Well, the patient gets some nitroglycerin and suddenly drops his blood pressure down to the 60s, but his lungs are still clear. Well, what's going on there? This person's probably developed a right ventricular MI as well. About 1/3 of inferior wall STEMIs will extend to the right ventricle, and they can significantly drop their blood pressure with any nitrate. So he went ahead and got some right-sided leads. V3, V4, V5, V6 are on the right side of this patient's chest, and you can see that in these leads, these right-sided leads, at least V4, V5, V6, all have ST segment elevation. Even a 0.5 millimeter is all you need. If there's ST elevation in those right-sided leads, that confirms that there is right ventricular extension of the inferior MI. And what that means is that you've got to be aggressive about giving IV fluids to this patient and stay away from preload reducing medications. If somebody has knocked out their right ventricle, they need preload. The way I think of it is that the purpose of the right ventricle is to simply get blood to the left ventricle. But if you've knocked out your right ventricle, you've got no way of getting blood to the left ventricle except what your preload is. If you don't have enough preload, or if you give patients medications that knock out the preload, there's nothing to fill the left ventricle, and the person's going to drop their blood pressure. And that's exactly what happened here. The patient doesn't have a functioning right ventricle. Now you give the patient nitrates, and that takes away any preload they've got, and they're going to significantly drop their blood pressure. So the way you treat this is the patient needs IV fluids, IV fluids, IV fluids. So they got plenty of IV fluids. He also tried some atropine because the patient was a bit bradycardic, and shortly after the atropine, and especially with the IV fluids, the patient's blood pressure came back up into the 90s and then above 100. They activated the cath lab. They sent the patient right up to the cath lab, and no surprise, this patient's got 100% right coronary artery occlusion. Actually, the patient ended up having triple vessel disease and ended up needing to go for cardiac bypass surgery on top of that. The patient fortunately ended up having a good outcome. So that's it for the case. Let's do some quick take-home points. And again, we're going to go beyond just the EKG take-home points. What are some key take-home points from this week's case sent in by Daniel? Well, first, remember, of all the things that we've learned to ask questions about in patients with chest pain, it turns out that there's only 4 that are incredibly specific for ACS. Now, I'm not saying don't ask the other questions. Of course, you're going to ask, was there shortness of breath? Of course, you're going to ask to describe the pain. Was it pressure, tightness, squeezing? But the literature actually says all that other stuff is non-specific. The 4 most important and most predictive features of ACS in that history are chest pain that radiates, and bilateral is worst of all. Radiation to the right side is next worst, and then radiation to the left side is a little bit less concerning. It still concerns me, but it's a bit less concerning. Definitely bilateral or right-sided radiation of the chest pain is worst of all. Chest pain with diaphoresis, we always say if your patient sweats, it ought to make you sweat. Chest pain with vomiting, not nausea, but vomiting ought to really make you worry. And also chest pain that worsens with exertion. These are the 4 most predictive features that tell you that patient is most likely going to rule in for ACS. So always ask your patient these 4 questions. Did your chest pain radiate? Was there any diaphoresis? Was there any vomiting? Did your pain worsen with exertion? And there's a few references for you if you want to look that up on your own. What else? We talked about the definition of sinus rhythm. Sinus rhythm should be defined by upright P waves in the limb leads except AVR, and the PR should be at least 120 milliseconds. If the PR is shorter than 120, think about a junctional rhythm. And if the P waves are not following this pattern, if they're inverted in the limb leads or upright in AVR, then that points towards an ectopic focus of where the impulses are coming from. All right. Serial EKGs were obtained in this case, and this is another nice example of the importance of getting serial EKGs or ECGs. And also, key point here, if you're only going to take away 1 pearl from this entire case, this is it. Please remember that reciprocal changes can precede ST elevation in STEMI patients. So, try to start paying attention to and learning about reciprocal changes, especially lead AVL. When you see flip T waves in AVL or ST depression in AVL in a person with ongoing chest pain, especially if they're new, you better get some repeat EKGs on that patient because that may be an impending inferior wall STEMI. All right, so at least get 1 or 2 more ECGs and make sure that they're not turning into an inferior wall STEMI. All right, and then finally, with the inferior wall MI, always consider that 1/3 of those patients will extend to the right ventricle. So go ahead and get right-sided ECG leads, and if there is evidence of ST elevation on those right-sided leads, stay away from preload reducing medicines like nitrates. Otherwise, they're going to really drop the pressure. Be aggressive about getting IV fluids. Monitor those lung sounds while you're giving IV fluids to make sure that that patient's not developing pulmonary edema. Patients with right ventricular MIs are very preload dependent. They need a lot of IV fluid. All right. So my thanks once again to Daniel Kwan for sending this case, and I look forward to talking to all of you once again on our new website next week. Bye for now.